there was a big hole in the program.
They do not know what watches and clocks are.
They don't believe that we have an equal right to life.
The current Ebola outbreaks the world.
This is the worst thing any of us have ever seen.
It's not one person, it is an entire mindset. To build stable institutions where none existed.
Health, which is a state of complete physical.
There was a part of me that felt overwhelmed by it because I was wrenched into the reality that I quickly realized was for much of the world.
Health for all is the future.
What is the nature of our responsibility in the world? Is there something like an area of moral clarity?
When we took the blame off the patients and put it on the system, everybody got better. Health for all is the future.
Wow, what a powerful movie and a great opportunity to be with each of you today. I'm Mikkel Moore. I'm Chief Community Health Officer at Intermountain Healthcare, and it's my pleasure to be joined by Dr. Kim and Dr. Farmer and Dr. Harrison. I'd love for each of you to take a moment to tell us who you are, even though that doesn't really, you don't need an introduction after this film, but please go ahead, Dr. Farmer.
I'm Paul Farmer, and I'm a physician and anthropologist, teach at Harvard Medical School, and in the 80s started Partners in Health with Jim and many others.
Thank you. Dr. Kim?
Jim Yong Kim. I'm originally trained as a physician and an anthropologist like Paul. That's where we met in our training program. A founder of Partners in Health, but also had a few other side jobs. One, I was president of Dartmouth College. And then after that, I was president of the World Bank Group for about 7 years.
Thank you.
But those were all side jobs. My real job was working with Paul, which we did through the entire time.
Master of side jobs. Dr. Harrison, please introduce yourself.
Thanks, Mikkel. I'm Marc Harrison. I'm president and CEO of Intermountain Healthcare, and I am a pediatric intensivist who thinks about nothing but public health now.
Thankfully. So I want to start with you, Dr. Farmer. This is such an important film for the correlation between what you saw in Haiti and what is going on in our own communities here in the United States. What themes do you see that might be applicable to our rural and urban communities here in the United States?
Well, one of the things that lent clarity, to pick up on Jim's expression that was in the clip, that lends clarity is when you're in a medical desert, right? Meaning there aren't the staff, the stuff, the space you need, the systems, the support. None of that is there. And if you're lucky enough and persistent enough and work with people in that clinical desert, you can water it and see it blossom. But it takes time, and it takes certain design features. You know, I'll just give an example of one. When we were in rural Haiti, there were no physicians or clinics that were really functioning, but there were also no community health workers. If you go to Boston, there are functioning hospitals and clinics, but there are also no community health workers. So again, you know, you look at the various places where you're working, and in this case, you mentioned Haiti, and then learn lessons that can be applied elsewhere in different form, perhaps. But you know, we've seen this again and again over the decades, that some of what we learn in one place is going to be very useful in another. And Jim has always pushed for us to find what's reducibly universal and useful everywhere, and use that as a building block to help build or rebuild healthcare systems.
I can learn to understand you much better if I can get familiar with the way you talk. I need your permission to help.
Oops, sorry.
I can learn to understand you much better.
Sorry.
Google Assist.
Jim, I've been waiting for you to say that to me for years, that you can learn to understand me better.
I'm so sorry. Okay. All fixed. Okay.
Thank you, Jim. So I wonder, Jim, if you might comment, you saw how destructive poverty can be in your work in Haiti. And I wonder if you might comment on what experiences you take from that could be applied here in the United States or elsewhere.
Well, the Haiti was really, for so many of us, Haiti was where we learned about how the world really works. And my first trip to Haiti was just an eye opener. I mean, I was a fully trained anthropologist by that time. I'd visited lots of different countries, had seen poverty, but getting on a plane and just flying for 45 minutes and then seeing poverty like I'd never seen before, the horror and the and the viciousness of it. It's what it felt like. It felt like that there was a kind of viciousness to allowing a country 45 minutes off the tip of Florida to look like this. And it was one of the most fundamentally disorienting experiences that I've ever had. And here I was, I finished medical school. I finished all my research for a PhD dissertation, and so it kept it, and so Paul was my teacher at that time, and getting my head around the fact that this exists so close to Florida was, I think, really important in me. In my making this commitment, I knew I wanted to work for social justice. I knew I wanted to do something around poverty, but the experience in Haiti taught me, okay, so this is going to be a long fight. There are situations like this all over the place. This is the worst in the Western Hemisphere, but in Africa and other places, there are situations that are like this. We will, and we thought at that time, we will never be celebrated. We will never, have much money. We'll always be on the losing side. But that's going to be the mark. That's going to be the source of our integrity. That we will stay on the side of people like landless peasants in Haiti forever. We will never back off. And the amazing thing is that as we took on bigger problems, or maybe took on the same problems on bigger stages, what lots of people would call success came to us. Partners in Health is very large now. Paul's a university professor. I had these very interesting side jobs, and so that's what people see. But the reality is that we've always stuck to that fundamental mission, that we will not leave the side of landless people living in poverty and who are landless, the poorest of the poor. And we were able to do it, though, on larger stages. In fact, when I went to the World Bank, the first thing we did was establish a goal for the end of extreme poverty. I mean, they almost killed each other because there were arguments about, well, what really is the end of poverty? How close can you get? There's friction. I mean, it went on and on and on. But we have a goal by 2030 to have people living in extreme poverty be less than 3% of the population, which is a hugely ambitious goal. So we never left it. The other thing, Mikhail, that I want to say is that what we also learned is that when it came to poor people, public health experts had this just incredibly, what's the right word, frustrating tendency to have very low aspirations, nihilistic, and sometimes, in complete denial. You can't do it. It's too complicated. They're so poor. If you do that, you can't do other things. It was just so what our mentor Howard Hyatt used to call hangdog, the hangdog nihilism of the public health world. The thing that I couldn't believe was that kicked in here in the United States once COVID started. We Paul and I talked early on, we couldn't believe that public health experts in the United States were giving up on the things that, for example, are well in place in Rwanda, are well in place in Korea, in Hong Kong, Taiwan, China, well in place in lots of other places that have been successful at suppressing the virus. We just gave up. And Johns Hopkins had said the US is the best prepared nation in the world for pandemics, and we gave up. And so there's something going on here, Mikhail. That hangdog nihilism, we have to, I think deeply, be self-critical. How is it that we let that happen? And the outcome was just as bad. It's the poor, it's African Americans, it's Native Americans, it's the people who can't afford to not work. They're the ones who are suffering most. And so we saw it in Haiti, and unfortunately, it's relevant. Those lessons are relevant to this very day.
They certainly are. And, I think we've experienced that from this perspective of a health system. And Dr. Harrison, I'd love for you to comment, as Dr. Kim describes, traveling just 45 minutes and seeing such dire poverty. We know we don't have to travel that far to see it, that there's inequities we encounter every day and people who need to be supported just in the way that Dr. Kim describes. What can Intermountain do? What is Intermountain doing? And what can health systems all across our country do to help in this way?
Well, Mikkel, as you know, because we've been co-authors of this work, a lot of it's based on the approach that Paul and Jim have laid out. Paul and Jim and I have some mutual friends who told me I need to watch Bending the Arc. I have to watch it. And I did. I always listen to what Geraldine says, and I always listen to what David says. And so I sat down and I watched the movie. And in addition to touching me deeply, the immediate connection I saw was that the approach for communicable diseases that Paul and Jim lay out, it should work for social ills as well. And that's when we began a lot of our conversation, Mikkel, around how do we, in a substantive, intentional way, begin to work on the social determinants of health, and how do we use all of our resources to begin to change the fundamentals for folks, and how do we now use community health workers, albeit far fewer than we actually need, to begin to touch the communities that are disproportionately affected by poverty, but by extension, all the ills associated with that. And it's been a ton of fun, but boy, is it hard. And it also blurs the lines between, I think what a regular question that we get is that really healthcare, that what you're doing? And I always segue back to are we a healthcare system or are we a health system? And if in fact we're a health system, it becomes extraordinarily relevant to worry about food security, transportation, housing, et cetera. And one of the things I'd love to hear Jim and Paul talk about as the time wears on is this idea around getting alignment of incentives. One of the things I worry about is that in a healthcare system, the incentives are aligned to do lots of things to people who are already sick. And I think we've worked really hard to get our incentives aligned so that it's really about keeping people well. And then the work we do around, for instance, affordable housing becomes a sustainable business model as opposed to charity.
And maybe it would be good to hear that comment now from Dr. Kim and Dr. Farmer. And if I could add to that, given Jim, your comments about how our country's responded during this time, what is the role of health systems? What's the role of public health? And how does our system need to evolve in order to create the right incentives for producing health?
Well, Mikkel, this is something that I think between Paul and I, we've participated in 5 or 6, maybe more reports that basically said something like the pandemic could happen, so we better prepare. I mean, this goes back to after SARS, right, Paul? I mean, we've been part of this and that and the other panel. And the last thing I was involved with was a UN World Bank document published in October of 2019 that said, COVID can happen. We're not prepared. We better get prepared. And the focus was mostly on developing countries. But what we've seen is that we were not prepared even in the United States. And so I had coined a term at the bank, and I said, why is infectious disease always this cycle between panic and neglect, panic and neglect? And so here we are in the middle of panic. And unfortunately, I feel like we're just about to get into neglect. The thing that's worried me most is how we haven't been able to, in Marc's words, align incentives. Because I've worked with a lot of the biggest business leaders, And I said to them, you know, guys, it's not the time to like look at the stock value of Pfizer, you know, to see if you can invest. It's time to put in place the systems that have been the only things to bring the virus under control, which is testing, tracing, and what we call supported isolation and quarantine, because not everyone can do that. Not everyone has a 5-bedroom home. That's the only thing that's proven that you can bring this virus under control. And they go, oh, no, we're going to have a vaccine, and you know, they're going to have better treatments. And frankly, for the wealthy people who have 5-bedroom homes, who have several 5-bedroom homes, it's really not a major issue. They know they're going to get great treatment. They're going to be fine. And so, you know, we had some success with the Democrats. I mean, you know, Paul and I have both worked with Speaker Pelosi for a long time, going back to the AIDS movement. And she put into a bill $75 billion for something they call testing, tracing, and supported isolation. And unfortunately, in the Senate, they explicitly carved that out. They did not want to put money there. So I said to the business leaders, you know how crazy it is to attack this problem only with fiscal stimulus and not public health funds? And they said, yeah, but you know, what we need is the fiscal stimulus, and there'll be a vaccine. You know, the news of the vaccine is great. There's nobody that's going to be happier about that than us. But the other side of it is that I hope what we learn is that even if you have a great vaccine, you need a great ground game. You need community health workers. You need, you know, the community-based contact tracing, isolation, quarantine programs to even deliver those vaccines effectively. But, you know, Mikhail, I hope I'm wrong, but unfortunately, what I think we may look at is that if the vaccine is successful, we'll go right back to neglect. We won't build the public health systems. We'll say, you see, we're going to get this every time. And then something's going to happen that once again is going to send us into this kind of situation, right? So the alignment of incentives, you'd think, you know, with the losses that we've seen in the business world, that we could finally align them, you know, for public health. But there's a reason. I mean, I was telling Marc before we went on that you know, we are so admiring of what Intermountain Health has done, because you have so effectively integrated public health with your healthcare system. And you know, everyone has to do that. But at 2% of expenditures on public health and 98% on curative care, if we don't move from there, we're going to be vulnerable to this again and again and again. But unfortunately, I don't think yet the business community, for example, understands this. And it's partly our fault, because we haven't communicated clearly enough from the public health community.
I completely agree. And, you know, we're very fortunate, I think, at Intermountain to have some of the incentives aligned to create that. Paul, is there hope of creating that type of incentive change to drive this at a more global or national level?
Oh, yeah, there's always hope of that. You know, we can entrap ourselves into decency, sometimes through legislation. I mean, you know, the kind of distortion that Jim just mentioned in a budget, you know, it's not as if it's passed down on, you know, stone tablets or something. So, you know, a certain amount of optimism and grit are required to do that, but none of it seems insuperable. You know, and I think the neglect panic cycle needs to be broken, of course, as Jim said. But we'll bend it one way or the other, because, you know, right now is a time to seize the levers and think about some things that can make a real difference. I'll just give one example. Back to contact tracers. You know, when we hear the incoming administration talk about, you know, recruiting a large army of 100,000 contact tracers, we're able to say, wait, that's not a large army at all. That's not even a battalion. And, you know, and have some hope of being heard. That hasn't always been easy. You know, things vary with administrations in Washington, but, you know, it seems to me there's more possibility of a groundswell for addressing things such as those Marc mentioned. You know, can we walk and chew gum at the same time? Can we take care of the critically ill and injured as we also address some of their upstream problems, whether it's in housing or food insecurity. And the answer, of course, is yes, we can. We've done it in the past. Other nations with far fewer resources, like Rwanda, are doing it. And so the answer is, yeah, we can change this.
Marc, I know you believe we can change this. Do you want to comment on Paul and Jim's comments before I go to the next question?
You know, I would, Mikkel. And, you know, as you know, I'm a great admirer of our elected officials. I think they have really hard jobs and they serve incredibly diverse constituencies, and the tools that they have at their disposal are either inspirational, aspirational, or legislative. And legislative tools are sort of blunt-edged weapons at best. I am very supportive of CMS's ongoing dedication to transforming how people are paid for healthcare, more and more towards value. I don't think it's going to be sufficient or fast enough to make the changes that they're actually necessary. And I want to use Intermountain and other systems to actually to make those changes. I want to use the private sector to make that transformation towards value-based care. And you know, Jim and Paul may not know this, but we've had 2 major acquisitions in the last 15 months. We've added another now about 500,000 lives that we're paid to keep people well, and these include a lot of poor and vulnerable people. And we have a lot more growth ahead of us, and in fact have publicly invited other healthcare systems to join us in an approach to change their model so that the incentives are aligned, so that it makes sense economically as well as socially and morally to keep people well. What's really interesting is in just about a 2 or 3 week period, we had another 6 systems who are very credible that represent about $20 billion in revenue, and millions of people who they care for who have asked if they might join. And you know, I think that bodes well for developing a credible alternative in the United States to volume-driven systems where people are just simply paid based on heads and beds as opposed to the health of a population. So we're all approaching this in slightly different ways, but I think Jim and Paul and I share that belief that we can make change, and we in fact must make change.
We must, and you're right. It's got to come from multiple sectors and from different perspectives. Thank you for the leadership you're providing in that, Marc. I want to now share a segment from the film. There was a particular segment that touches on the concept of social justice, and I'd like to run that clip and then pose a question to you, Jim.
I think my father taught me something really important, that if you come into a situation with something that actually can help another person, it's a good entree to begin a different kind of conversation.
When Jim arrived in Cannes, he was a very keen observer of everything that was going on there.
I really see that as my apprenticeship in understanding how you take a notion of social justice and turn it into real work on the ground. We decided this could be something like a movement.
So, Jim, how do you take these broad issues and bring it to real work on the ground here within the context that we're talking about, healthcare in America? How do we put it to work on the ground?
Let me give you a really concrete example that is just straight out of the daily call, the 3 days a week calls that we have at Partners in Health. Something like just doing contact tracing. We found that 20% of the people we call need food support, right? So what we did was we created another part of the contact tracing program called the resource managers. I think that's right. And they're in charge of making sure that people who need to isolate or quarantine have what they need, from food to diapers to whatever. 20% in Massachusetts needed that support. And so Well, what we've been saying is, well, why don't we align the real incentives instead? If we're spending now, I think upwards of 4 trillion in fiscal stimulus, which is great. I'm totally for it. We need it. What if we just spent 5%, right? So 4 trillion, 5%, that's 200 billion. We've never had 200 billion for a comprehensive public health effort. But if we did, think of the things that would result. People would have jobs. We pay $35 an hour in Massachusetts, and people work very hard, but they're making a difference in terms of the public health situation. Two, by having a program that specifically looks at people who don't have 5 bedrooms and simply can go to their summer home, right? We're actually making a huge blow for social justice. In other words, people are able to survive the pandemic much better because we are watching them. We're making sure they're getting medical care when they need. We're making sure they have food and other things that are critical. And thirdly, it's actual fiscal stimulus. One of the things that we learned at the World Bank Group is that if you give poor people money, they actually spend it, and they spend it pretty wisely, and it stimulates the economy, right? So when I went to the World Bank, I saw study after study after study looking at cash transfer programs. And I said, why do we have so many studies on cash transfer programs? And they told me it was because people at the bank were so ideologically against actually giving money to poor people, right? That they had to study it and study it and study it. And guess what? We found out that in almost every situation, whether they're conditional or unconditional, it has a positive impact on health outcomes, on educational outcomes, and it stimulates the economy. So, poverty by definition is not having money. So actually giving poor people money is, works. And we've seen that everywhere. And so there is a thing we can do right now, build this workforce at a much higher number, and not only, and then kill multiple birds with one stone. You got people with jobs, you got an effect on the pandemic, and you have fiscal stimulus, all things that you want. Now, I hope we can do it. But I worry that there's not going to be enough support. And, I want to get it on record now. If we don't do this, we're in trouble for the next pandemic. And we're just missing a huge opportunity to make a huge blow for social justice right here in the United States.
I agree, Jim. So Paul, how do we share the message that creating these types of improvements for the most underserved and vulnerable communities among us doesn't have to come at the expense of others? How do we create that that message and that understanding in a community that's kind of divided right now?
I think Jim and I spend a lot of time trying to keep a straight face as we're saying, well, actually, there's ample evidence that if you give money to poor people, they may be less poor. I mean, on and on. Another one, there's some evidence that if you have a chronic wasting disease and you don't have enough to eat, you might die from it. I mean, it's just absurd, right? And so you do have to, go, as the Americans love to say, to where people are at. And just before leaving that, for a very concrete example of what Jim just said about the impact of as stimulus money on creating jobs through contact tracing. I was on Zoom yesterday with a colleague from Navajo Nation, and she was saying that a number of their recent recruits for contact tracers are from the casino industry. They can't, the casinos are closed. That's not good for cash flow in Navajo Nation. And it's just so obvious that this is the time, right? Jim and I have been on this planet for 60 years, soon 61. And, this is the time to say, here's the narrative, just like Marc did. I mean, Marc laid out a very clear narrative about what he and the Endeavor are trying to do. The narrative now is we're facing a once in a century, if we're lucky, once in a century pandemic. It has resulted in massive disarray that all of you can see and feel. And with 250,000 dead, you can bet that a lot of people are feeling this in a very, very personal way. And now we're saying, here's how to transform the the illness care system into a healthcare system that does not neglect the critically ill and injured, but there's a lot more to make us healthier overall. And, you know, a lot of things that I just finished a book about Ebola, and the editor a year ago said, well, I don't know if an American lay audience is going to understand words like PPE, flattening the curve, you know, on and on it went. And then in February, he said, never mind, leave it as is, just add in something about COVID.
The title of the book is Fevers, Feuds, and Diamonds. It is an outstanding read. I urge everybody to Paul will never plug his own books, so let me plug it for him. It's a fantastic book.
Thank you, Jim. Thank you. That means a lot to me. And it's a reminder too, lessons from Ebola, for example, it's the same set of lessons. How do we stop Ebola? Well, the Atlantic Ocean had a lot to say about it, unfortunately. But in the end, after many, many false claims of having stopped it in West Africa, you know, it was this combination that Jim described, you know, contact tracing and supportive isolation. You know, if you're in a village in Africa, you can't just wall it off and say, hey, 21 days. People, even their gardens aren't in the village. They're sometimes miles away. So you know, that supportive isolation was very dramatically, the need for it was very dramatically manifest at that time. We're taking those lessons and saying, now is our time too. Here's where we can make a difference. So part of the optimism may stem from the extremity of the circumstance.
We're going to transition here as we're watching a lot of questions come in through the chat. And so I'm going to pose some of those to you. Paul, I think you're speaking to one of them that's come forward in a couple of different ways here, that what's needed here is leadership. Someone, I think Todd commented on that in our chat flow, and someone else commented that, you know, there doesn't seem to be any incentive to act boldly. What do you all think? What's the place for leadership here? And Marc, I'll go to you first.
You know, Mikkel, I think that there is no incentive to act boldly from a economic standpoint or a self-preservation standpoint right now. I think this actually comes down to what do you want to leave behind on this earth? And you know, we talk on our team, Mikkel, as you know, about, you know, what hill are you willing to die on, you know, professionally? And as you know, for me, it's these issues around equity. And one of the pleasures of the last 8 months or so have been the stark realities that anybody with half a brain can see around how certain populations have been disproportionately affected, almost genocidally affected by the pandemic. And if this isn't a strong call to action to try and leave the world a somewhat better place, I actually don't know what is. And this exists in non-pandemic times as well. You know, people have asked me, you know, what's been your best day at Intermountain? What's the best thing that ever happened to you in the last four years? And it'd be easy to talk about some of the great clinical achievements we've had, or some of the, you know, public policy things we pushed. But for me, it was going to get my blood drawn as part of my ongoing cancer journey, and having the phlebotomist, who often draws my blood, say to me, you know, Marc, I'm a gay woman, and in the last couple of years, it's the first time in 30 years of working at Intermountain that I can bring my whole self to work. And that actually means a lot to me. I mean, that was probably my best day ever. And I think if we can do that for the 40,000 people who work for us and the several million people that we serve every day, so that they can fully express their potential as human beings, both professionally and personally, and in the process make them a bit healthier, that's a hill worth dying on.
Absolutely. Paul, I wonder, we have a question from Marissa Henn in the chat. Marissa asked, by 2030, depression will be the leading cause of disability on our earth. And she's wondering if you could talk about Partners in Health's innovative global work in mental health. And, even as we think about the impact of COVID and this pandemic, and we know that the next wave of our concerns might be mental health related. How can your work at Partners in Health be a lesson for us here in the United States around how to address mental health and well-being?
Well, one of the things to note is that in a social field in which there is almost no attention going to mental health, it becomes innovative just to acknowledge that it's the ranking cause of human suffering in the world. So, whatever your metric, it comes in at the top as a cause of morbidity. And it's not an insignificant cause of mortality either. So the idea that we need strong mental health programs, it's kind of like saying, people who have a wasting consumptive disease might need to eat, or really poor people might benefit from actually having more money. We have to conclude, with the sloganeers that there is no health without mental health. And once you do that, again, in personal terms, it comes like it's seeing something bad happen in my case in Haiti, catastrophes that are related to unattended mental health or improperly diagnosed mental health problems. And again, it gets back to this formula. So you don't have any psychiatrists. By the way, psychiatrists are not going to solve this problem in the next 100 years at the current rate of training, even in Europe or America, or the United States. So you do need alternative models. So what we did was do the same thing we did around AIDS, tuberculosis, other diseases where it's helpful to have proper accompaniment. And that accompaniment comes from trained community health workers. Trained to do what? To deliver mental health services. They're the backbones. And then you have psychologists, social workers, clinicians with an interest in mental health issues, and psychiatrists where you're lucky enough to have them on the team. In Rwanda, when we went there, there were no psychiatrists in the country. And for many years afterward, the head of the mental health program is a very terrific psychologist who had, very little in the way of staff, space, or systems. And with the help of many, and I'm glad Partners in Health was part of it, built up a national program that stands them in good stead to this day, And so that's just an example of the way Partners in Health has tried to work with the public sectors, with communities, with the afflicted, integrating people who have lived with mental health or survived severe mental health challenges, integrating them into the work and moving forward as a collective.
So it seems so simple then. If we create a community health workforce that helps with a pandemic, helps with mental health, helps with food, you've got infrastructure for the public health needs of a community, regardless of what we face in an acute sense.
And if I could add one thing, Mikkel, it does not, just as when we talk about upstream social determinants, we had better not forget about the people who are already sick and already injured. So with mental health, community health workers aren't going to solve everything. There are people with acute psychosis who need inpatient care, supportive environments and medication. And when we went in Sierra Leone, for example, to the oldest psychiatric facility probably in post-colonial, it was pre-colonial Africa. It was founded in the early 19th century as Kissy Lunatic Asylum. When we went there, every single patient there was in chains, literally chained to a bed, chained to a wall, chained to something, and they had absolutely no medications. So again, staff, space, and systems. Where do you need what, and for how long? And that's what we're facing with COVID. It's a different situation. Now we have a chance to say, these are not the staff we need. We need more stuff, a vaccine, better therapeutics. We need more space, safe places to quarantine, for example. And we need, most of all, as Jim would say, much better systems.
So So Jim, I'm going to go to you with a question from Blake Fessler. Blake asks, how do you sell the idea of giving money or food or this type of support to the poor to fiscal conservatives who don't understand the long-term benefit?
Well, in this case, what we're talking about is something that will actually allow us to get back to business, and so that the businesses can function more effectively. I mean, so in China, they're pretty much back completely to normal, right? Even their air travel is only 15% less than what it was at this time last year. I don't know if any of you saw during the fall holiday in China, people were packed on top of the Great Wall, and you saw these pictures. They were wearing masks, but I thought, oh my goodness, that's risky. Total of 200 cases that came out of that fall time when everyone was traveling, everyone was congregating. And in the province where there were 200 cases, they did 4.5 million tests and locked down the city for a couple of weeks, and then went right back to business, right? So, that's what we're talking about, is the ability to do that so you can get back to your business. Now, I think that inside the World Bank, 25 years ago, there were a lot of fiscal conservatives then as well, but they showed the data, because what happens when you give poor people money, and especially if you do it in a conditional way, and the conditions are, you've got to go to a session about the health of your children, right? You'd love this, Marc. It was a session about how to keep your kids healthy, how to help them in school. Those were the conditions. Those programs worked extremely well. Household poverty plummeted. The school outcomes got better. But the thing that we didn't expect was that it acted as a direct fiscal stimulus, because poor people spend their money. When you give benefits like lower tax rates to rich people, they don't necessarily spend that money, so it doesn't stimulate the economy directly. So there's so many good economic reasons for it, but right now, and I hope things change. It's like, if you wear a mask, you're a Democrat. If you believe that the virus exists, I mean, we're hearing story after story about people who've gone to their deaths saying, I don't believe COVID exists, right? So we have a long way to go, but I think we can sell this as all the things you need to do in order to ensure that this doesn't happen to your business again.
Thank you, Jim. Great points. I'm going to ask one more question, and then unfortunately we're going to have to wrap up. This has gone so quickly, and this is for you, Marc. Part of addressing this challenge is looking at it through the proper lens. Should we be viewing all equity, from access to affordability, as a means of serving or achieving justice for the underserved?
I would say yes, but Mikkel, the way that question is framed in the wrong hands can become a political weapon. I actually prefer to address a lot of these questions as medical problems, and to think about how they relate to public health. I'll give you an example from our own system. I suspect that if you actually polled the 5,000 doctors with whom we work on a regular basis, some employed, some affiliated, you would get a diversity of opinions about the Black Lives Matter movement. Some super in support, a lot in the middle, some vehemently against. I actually don't know a single one of those doctors who won't be appalled by outcomes that are disparate based on the color of somebody's skin. And I think you can get an awful lot done by framing some of the issues we're talking about simply, as let's make sure that people get the outcomes they deserve. And we're seeing that work in real ways. And then the other piece that actually I think bends that curve is actually knowing people. It's interesting, you regularly run into people who want to assert that they are sort of woke because they say, my best friend is, and then you fill in the blank. But what that tells me is that they're neither ignorant nor uncaring. It tells me that once you actually know a person, it's pretty hard to dislike them, and that there are enormous opportunities to build shared beliefs that aren't about politics and aren't about terms like social justice. And I think that hopefully social justice will come from the good work we're doing in the interest of the health of the folks that we are privileged to serve.
Something you said there, I think is so important. Is this for you, Marc, and for Intermountain Healthcare? This isn't charitable. This is core to the mission of the organization and core to what we're trying to accomplish. And thank you for your leadership.
And yours.
Thank you. Well, it is time for us to close. And Paul, Jim, Marc, I have enjoyed this all so much and am grateful for the impact that you're having in your work at Partners in Health, Paul and Jim, and Marc for our work at Intermountain. And there were lots of questions we didn't get to in the chat, but I think through your leadership, know that the influence you have on the future of the medical profession in our communities and here in the United States has great opportunity for power and influence, and encourage you to look at those comments in the chat. And I just want to close by thanking each of you for not leaving the sides of those people who need us most. I think if we can all find ways to do that by, Marc, as you suggest, knowing one another, when we truly do take the moment to know one another as human beings, I don't think anyone can walk away from the side of another. And as we think about how to connect that to our leadership in the various hats we all wear, we can make an impact in this world and in this country. So thank you for your time today.
Happy Thanksgiving.
Happy Thanksgiving. Great to be with you.
Thank you all.
Happy Thanksgiving. Stay safe and have fun.
Great. Everybody stay safe. Thank you.